All right, let's dive right into this masterclass explainer on fetal heart rate monitoring. Today, we're taking a complex, high-stakes clinical skill and turning it into a logical framework that's absolutely going to guarantee your clinical readiness. As a labor and delivery nurse, monitoring the fetal heart rate is, hands down, one of your most critical responsibilities. And why is that? Well, because these patterns are a direct window into fetal oxygenation and well-being. Catching abnormal patterns early? That drastically improves outcomes for both mom and baby.
Here's our roadmap for today's explainer. We're going to start with fetal baseline and variability, move right into accelerations and decelerations, tackle the NICHD categories, break down intrauterine resuscitation priorities, review uterine activity and physiology, and then wrap it all up with a high-yield exam review.
Starting things off with Section 1, Fetal Baseline and Variability.
So the very first foundational metric you need to lock in is 110 to 160 beats per minute. When the heart rate sits right in this sweet spot, averaged over a 10-minute window, it tells us there's excellent uteroplacental perfusion. Now, if we see it drop below 110 for 10 whole minutes, that bradycardia is a massive red flag that can signal prolonged cord compression. On the flip side, a sustained rise above 160 is tachycardia, and that should immediately make you suspect maternal fever or infection.
But we can't just look at the baseline, right? We also have to look at variability, which is those irregular fluctuations in the heart rate. It ranges anywhere from absent, which honestly looks like a really concerning flat line, to minimal, moderate, and marked. The absolute crucial takeaway for you here is that moderate variability, meaning fluctuations of 6 to 25 beats per minute, is exactly what we want to see. It's your best friend. It tells us the fetal central nervous system is perfectly intact, well oxygenated, and definitely not experiencing acidosis.
Moving right along to Section 2, Accelerations and Decelerations.
Okay, accelerations are those highly reassuring signs of a happy, well-oxygenated baby. We define them as abrupt increases of at least 15 beats per minute above the baseline, lasting for at least 15 seconds. You'll often hear this called a 15 by 15. They pop up all the time with spontaneous fetal movement, and you know what the best part is? They require absolutely zero nursing intervention. Seriously, you just document it, smile, and keep going.
Now, decelerations are a different story, and everything hinges on this specific cause and effect matrix. Early decelerations smoothly mirror the mom's contraction. They're just caused by benign head compression as the baby descends, so you don't need to intervene. Variable decelerations, though, those are abrupt V or W-shaped drops caused by umbilical cord compression, so your immediate move is to reposition the mother to get the weight off that cord. And finally, the scary ones, late decelerations. These start after the peak of the contraction and are a glaring red flag for placental insufficiency. They demand immediate intrauterine resuscitation. You literally cannot ignore these.
We also really have to keep our eyes peeled for prolonged decelerations. If a deceleration lasts longer than 2 minutes but less than 10, it officially becomes a prolonged deceleration. This is a highly non-reassuring pattern. It's usually linked to things like maternal hypotension, tachysystole, or rapid cervical dilation. When you see this, it demands an immediate emergency response from you before it permanently wrecks that baseline.
That brings us to Section 3, the NICHD categories.
This is truly a tale of two extremes. Category I is your gold standard, perfectly normal tracing. Normal baseline, moderate variability, absolutely no late or variable decelerations. It just means routine care. But this contrasts sharply with Category 3, which essentially screams unexpected fetal acid-base status. A Category 3 tracing means you've got absent variability combined with recurrent late or variable decelerations or even bradycardia. There's no waiting around here. It requires immediate intervention and preparation for an emergent birth.
So what about everything in between? Well, that falls into Category 2. These are your indeterminate findings, things like minimal variability or occasional late decelerations. The acid-base status of the fetus just isn't crystal clear here. And this is exactly where your clinical judgment as a nurse is desperately needed. You have to step up with ongoing observation and corrective measures to see if you can improve the picture.
Let's look at how to fix those issues in Section 4, Intrauterine Resuscitation Priorities.
When things go wrong, you have to follow this clinical priority ladder. Step 1. Reposition the client laterally. This relieves vena cava or cord compression and gets that blood flowing again. Step 2. Push an IV fluid bolus to correct any maternal hypotension and boost that intravascular volume. Step 3, and this is huge, discontinue oxytocin or any uterotonics immediately. You have to relax that uterus and stop the contractions that are stressing the baby. Step 4, administer supplemental oxygen if the mom is hypoxemic.
And finally, if the tracing still isn't improving, you notify the provider and prep for an emergency birth.
Next up is Section 5, Uterine Activity and Physiology.
Remember, we can't look at the baby without looking at the uterus. We measure contractions by their frequency, duration, intensity, and resting tone. This brilliantly illustrates why a rest period between contractions is literally vital. The placenta desperately needs time to refill with oxygenated blood. If a mother is having more than 5 contractions in a 10-minute window, that is tachysystole. Sustained tachysystole cuts off blood flow to the spiral arteries, and it will cause severe fetal hypoxia. You have to give the uterus a break.
You always want to connect the tracing you're seeing on the monitor back to the physiology. If a mother is hypotensive, maybe she just got an epidural, it directly compromises the uteroplacental unit. If she's lying flat on her back, vena cava compression is tanking her cardiac output. If the umbilical cord gets compressed, it triggers a vagal response and drops the fetal heart rate. Understanding the why behind the monitor is exactly what empowers you to fix the what.
All right, let's bring it all together in Section 6, High-Yield Exam Review. First things first, avoid these classic student traps. Never ever mix up your early and late decelerations. Remember, early is just harmless head compression, while late means dangerous placental insufficiency. Also, do not forget that stopping oxytocin is your absolute top priority if that uterus is contracting way too frequently. And write this down, moderate variability is always a sign of a happy, oxygenated brain. Let's apply all this to some high-yield scenarios you're definitely going to see. If you spot recurring late decelerations, that screams placental insufficiency, so you need to immediately reposition the mother and get those fluids going. If maternal fever is driving fetal tachycardia, your intervention is antipyretics. And if that monitor is showing you a Category 3 tracing, telling you there's fetal acidemia, your immediate priority is prepping for birth. Don't hesitate.
Continuing our rapid-fire review, if you discover a prolapsed cord, your absolute first priority is elevating the presenting part away from that cord. If you see tachysystole from overstimulation, you shut off the oxytocin immediately. And you must be able to recognize the sinusoidal pattern on the monitor. It's this incredibly smooth wave-like line that indicates severe fetal anemia, and it requires absolute emergency intervention.
Finally, let's lock in these specific clinical indicators. Moderate variability and a baseline between 110 and 160 are your ultimate proofs of effective perfusion. And a quick medication safety check. Never give Hemabate to a patient with asthma, and always check a patient's blood pressure before administering Methergin, because it is strictly contraindicated in hypertension.
By mastering these patterns, the physiology driving them, and the exact nursing interventions they require, you are perfectly equipped, not just to pass your licensure exams, but to actually thrive on a busy labor and delivery unit. It's all about applying the right intervention at the exact right moment.
Fetal heart rate monitoring is your window into the womb. It's how the baby talks to you. So my final question to you today is this. When you step up to that bedside, the alarms are blaring, and you see a Category 3 tracing flash on the screen, are you ready to trust your knowledge, stop the oxytocin, turn your patient, and decisively act to save a life? Take these concepts to heart, study hard, and I'll catch you in the next explainer.